Hi, Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio here. We're happy to have you back with us today. It's a big day here. A lot of things are going on in the COVID world. Of course, Hawk is going to give us the numbers for just a moment. In just a moment, Carrie Raleigh is a patient who has cancer, and she's going to tell her story in just a minute, and she survived COVID. And we're going to hear from her medical oncologist, Dr. Laura Nye. So it's good to be with you here today. But the numbers, Hawk, the numbers are very not good. In fact, they're a little alarming, I think.
Yeah. I mean, I remember when we had in the teens.
Yeah, I did
just a couple weeks ago, and we were happy. We were happy when it was 30, although we wished it was less.
Yeah, in fact, I think you said, "Oh, it's bad. It's really bad." One day when we got to 35, and we're double that.
We are 72 now active patients in the hospital. 25 of those in the ICU and 16 on the ventilator. We still do have 36 other patients here who are in that recovery phase, but luckily only 3 on the ventilator, so that's good too. But overall, it is a large number of people who really wouldn't otherwise be in the hospital.
Yeah. So how many recovering did you say? 36?
36. Yeah.
So if we put 72 and 36 together, we have 108 beds of our hospital occupied by COVID right now.
Yep.
Yeah, that's a really big number, huh?
Yeah.
Influenza.
No.
Maybe get to 20% of that. So once again, a clear proof that this is not influenza.
Yeah, absolutely. And, luckily, our partners in Hayes have kind of seen their numbers decrease a little bit. They have 16 patients, 12 are active, so 4 in that recovery phase. So, but again, why are these people here in the recovery phase? Probably because they're still extremely weak. They may need supplemental oxygen, breathing problems, other issues that have happened because of COVID. So they still have not been able to be discharged, but hopefully they will get to that point.
And we think of like a Neil Garmarker who's been here multiple times afterwards trying to have surgeries on his trachea from having to be on a ventilator for so long, and other issues that have come up. And this is not influenza. I know people want to make it so. It is not so. So just stop with the influenza stuff. It's just wrong. Okay, let's hear if there's first Jill, see if there's questions from media this morning.
Hey, good morning, Cody with Channel 9. I saw Monday the FDA granted emergency use authorization for the Eli Lilly monoclonal antibody treatment for adults and kids. I know you guys have talked about these treatments before. But I just want to get your thoughts on the news and how this may affect treatments here at home. Could this potentially ease the strain on hospitals?
We sure hope so, Cody. In fact, I think that's like some of the best news. People are really excited yesterday. Yesterday was a big COVID day news-wise, both from the rapid rise in the country, the rapid rise in Kansas City, but from the side of hope, because the vaccination news yesterday was, that was great. I said to somebody, that's like a grand slam home run in the bottom of the ninth, and that's a really big deal, that 90% effectiveness. I think the monoclonal antibodies are going to turn out to be another grand slam. That's another really big deal. They have to be given as an outpatient, and Hawk can help address this in a moment. I think there's been 100,000 doses ordered, or 300,000 doses, maybe 1 million by the end of the year. But you got to remember, we got 100,000 new diagnoses in the United States on a daily basis, so there won't be nearly enough drug to go around. We have been a study site for the Eli Lilly drug, and I remember when Dr. Castro was here talking about it, perhaps 3 or 4 weeks ago, and said it felt like the patient, you could kind of tell who was getting the antibody and who was getting the placebo. And I think it's because people felt better. And I think that's exactly what we're seeing in this early use authorization. It doesn't mean it's FDA approved. It means it's now allowed for use because you're in an emergency use, means it's an emergent time. We can give the therapy. The data looks pretty responsive, pretty impressive. The information that was published in the New England Journal of Medicine on October 28th talked about a drop in the hospitalization rate overall from 6.5% to 1.6% of the patients who got it, and in high-risk categories from like 10 or 11% down to 3%. Well, if we cut the hospitalizations in half or by 75%, man, you just heard us say we have 75 patients. That takes us down to 25 patients, and hopefully those 25 aren't quite as ill because they got it. So, I mean, it's really a big deal, but I think that you have to remember that these drugs are actually harder to produce than the vaccines are for a variety of reasons, and so it's not going to have a whole lot of medication at once. I did look at the early use authorization form. We're going to be a distribution site for Eli Lilly for this drug, and what I can tell you is that the initial criteria are age over 65 or BMI over 35. Now that you can use it for other high-risk categories like a transplant patient or something like that, but that's kind of who you're aiming at first, only because there's not enough drug to go around. So I think we just have to remember that it does look really hopeful. We are really excited about it. It's still early use. We don't know all that there is to know about it. There's not enough drug to go around necessarily, and it takes a while to make it. Hawk, additional thoughts that you would have?
We certainly don't know when or how much we'll get, but we have been working with the team, Nathan Barr, as well as our ID pharmacist, Nikki Wilson. We've all, they've been working for the past 4 weeks to put all the stakeholders together because, just as you said, it's an outpatient infusion, so it's likely going to be giving at another site, not here at the hospital, but one of our other sites. But it's all of the other protocols and procedures that we need to make. But we've been working on those, as well as, again, like you said, risk stratification. And not everybody who is going to get it, we've always said 80%, 85% of the people will never need to seek medical care for this. So there will be a risk stratification there in determining who is going to benefit and who will need it.
And this is the drug. Actually, Regeneron also has a drug with it. It has the early use authorization. Eli Lilly is the one that Governor Christie got and President Trump got, the Regeneron drug. And so I think Regeneron will have similar numbers. What this should tell us, Cody, and I know it's a much longer answer than you probably wanted, is the more we can bend the curve, the more we can make sure we have drug available for people. So,
all right, thank you.
Other questions?
So I have a couple. One from the Kansas City Star. They want to know, with the alarming number of patients, what steps has the University of Kansas Health System taken so far to manage capacity, and what's planned?
Yeah, that's a great question. I tell you what, right now we've tried to pull rabbits out of our hat. That doesn't really work for bed capacity. So you're left with trying to do the things that are real. There are two problems in the community, and then and every hospital is a little bit different. What we know is that there are not enough staffed beds. Now we don't have that issue here at KU. We all our beds are staffed, and in addition, we're staffing what we call alternate care locations. So if we have to keep people overnight in the GI lab, in some of the open the beds there, or in the dialysis lab and some of the beds there, we are doing that, and so we're having to staff more beds than we would normally do. So it's not that we have staffing concerns, everybody does, but thus far our staff have done a great job. They've really rallied around this and allowed us to operate at times over our what we would normally have with these other alternate care areas. So that's been great, but as the COVID numbers continue to rise, and when you have 108 or whatever that number is this morning, beds occupied that would not normally be occupied at this time of year. It's a busy time of the year to begin with, just because you run into the cold and flu season. And unfortunately, we're not seeing a lot of influenza yet, so that's been great. But there are other things that happen this time of year. And then you think of all the patients out there who want to get things done before the year runs out because of their deductibles. That just creates a lot. This is the busiest time of the year for us. And now we have 108 more patients in because of COVID, and those patients are sick. So what are the things you can do? We can stop taking transfers from outside hospitals, which we've had to slow that down. I think that's not the best answer, right? Because that hurts patients who need you. So at some level, we're beginning to say, well, we can take care of these folks, but that means we can't take care of those folks. And then the other lever is to stop doing elective surgeries or to cut that back, and we're actively looking at doing that. And I think we haven't started it yet, but it is under strong consideration, and the reason is that that's just one of the levers you can have to pull. And we keep hoping every day that curve will shift, and then we won't have to really think about doing that, because that really affects people. And when you start having to, it's not the same day surgeries, it's not outpatient surgeries that you think about them, because those don't take up beds. It's really those patients who are going to take up hospital beds. So it's people who are having surgery and they're going to have to be here for 3 or 4 days. That's not just a KU phenomena, by the way. That conversation we know is going on around the city. It's going on around the country. Yep. It's the same thing the lever that's been pulled in Utah and in Wisconsin and in Texas and all around where all these cities are hotspots and hospitals are full of COVID. So there's no magic lever. It's just the levers you can do to help as best you can. And then you try to discharge people as early as you can, because and you can't discharge them until they're ready, but sometimes you can try and discharge a little early. The other thing that's been a backlog for us is patients who needed placement, because there's been enough COVID in the nursing homes in Kansas City that, and in our area, and frankly in our state, by-state area, that a lot of the nursing homes weren't accepting new patients because they had COVID outbreaks. So until that was under control, we had a backlog of patients who had to get back to or were going to be placed into a skilled nursing facility you couldn't discharge to there. Rehab hospitals had the same challenge. So, that we're all in it together. This medical ecosystem, we all have to work in it as best we can together. So that at some level, there's just not a lot of levers you have to pull. You try and get as many staff in. You try and you can try and get PRN staff and traveling nurses, et cetera, but those things are hard and they're needed all over the country. And so the last thing we do is we try to preach. And I suspect you know what we're going to preach, because we do it every day, because it's the gospel of infection control. And we know that the gospel works. And I think we have to take care of each other. And we know the gospel works because right here in the hospital, in the wards where our COVID patients are, we have a lot of staff. And those staff aren't getting sick in those COVID wards. And why don't they get sick? It's because they follow the rules of infection control. They wear a mask, they wash their hands, they do the things they're supposed to do. Those rules keep you safe. All those people out there that are mask deniers, I don't know why you want to do that. We just have to get over the thought that this is a political thing. It's just not political, it's health. And really what we're doing is we're taking care of each other. So the preaching comes to the rules of infection control, because that's sort of our gospel here. And we need everybody out there to be a disciple, or to be a prophet, or whatever allegory you want to throw at this, to help us spread the word, because we've got to get people to understand that the way you bend the curve is not to ignore the rules. When you ignore the rules, the curve escalates. When the curve escalates, we as healthcare providers get in trouble, and that's where we are.
One last media question at this point. There is reports that a local school district is encouraging COVID parties, much like you would chickenpox parties, believing that herd immunity is the way to go to get us out of this pandemic.
Yeah, well, that's just a perfectly terrible idea. So there was a thing called the Barrington Report a few months ago, and I'm going to wax eloquently about this for just a moment, then I'll ask Hawkeye to take on too. It was written by some really smart folks who one was from Yale, and I think one was from MIT or maybe Harvard or something, and one was from Stanford. And I'll tell you, their own schools have discredited that report. They've said this does not represent our body of knowledge. But they said if we just had everybody run out and get infected, we could accomplish herd immunity, and everybody who is chronically ill or 60 or over should just shelter in place and stay at home, and the rest of us will all get it, and then we'll stop the spread of the virus. Okay, so first of all, that's just terrible. Because I don't know what world you look at in which you're going to pick and choose who can go outside and who can't, but we can already see that just doesn't work. Second of all, because this disease can kill anybody, trying to infect everybody all at once, it just means the hospitals will be totally overwhelmed. There's no way that can be functional. Third, it's immoral to even suggest that, because you will cause death and destruction that you don't need to do. Because all you have to do is follow the rule of infection control and wear a mask. So let's think about it. We can go get 200 million people infected all at once, with a death rate of around 0.5%, which if I do my math, that's going to be 1 million people will die just because you tried to do that at least. And when you overwhelm healthcare resources, probably 2 million. So that's a lot of death, and you're going to get more than 200 million people to accomplish herd immunity. But then the next thing is that the healthcare resources will be overwhelmed. So people with heart attacks and strokes and things like that won't be able to get into a hospital. So then you're just going to, those people are going to die too. So just think about the downstream, the cascade of that. It's just a bad idea, which is why the home institutions of those authors have all disavowed that work, because they said, no, that's a terrible idea, because it is a terrible idea. And so for anybody who's trying to do that, please listen and don't believe sketchy ideas written by people who don't really understand healthcare dynamic. And I don't know how to say it any different.
Yeah, absolutely. I think just in general, it's dangerous. We don't even know that you can't be infected. We have seen cases.
We don't even
of
know how long it lasts and reinfection. Yeah.
How long is your quote unquote herd immunity? What is that durability? And even if you get it again, is it going to be less symptoms? Is it going to be worse? They have a lot of good theories and thoughts based on I don't know what. But it certainly is not based in science. They want to keep the economy open. We want to keep the economy open. We want to keep people working and putting food on their table. There is that medium that everybody can strike so that we can keep those things going. But their opinions and thoughts really are not based anything in science, and that's the main point there.
Yeah, you just got to get a grip on the reality of life, and the reality is we have a pandemic, and the good news is that real hope is here, is about 2 to 3 months away between a vaccination and monoclonal antibody therapy. Early use authorization has been approved. We're starting to work on distribution, which means the drugs are on their way. It's just not some idea sitting out there in the sunrise. It is a real thing, and so you just got to be good for a few more months, and then the world's is going to change, and we can do that. And I think trying to do other things that are truly destructive is going to cause a lot of anguish and death that we don't need to do.
All right, we're out of media questions.
Lauren, now that we've waxed eloquently for so long, talk to us a little bit about medical oncology and help us introduce Carrie here, because I've been watching Carrie nod her head as we talked about how difficult this is and don't do herd immunity, because Carrie clearly gets it.
Mm-hmm. So Carrie is one of my patients who has breast cancer and has been on active treatment, and unfortunately also had COVID-19 infection this year, which has been a big hurdle in the cancer world to deal with COVID-19, because as we know, cancer doesn't stop for COVID, and we've had to figure out ways to continue our treatments and to continue our screening, which I know you talked about yesterday, and still take care of our patients without, hopefully, the threat of COVID.
So true. And Carrie, you think that you caught COVID from one of 20 trusted people at a going away party for your daughter who is headed to physical therapy school in Dallas. Talk to us about what happened, what your symptoms were like, and what your journey's been like.
Sure. Yeah, that is exactly what happened. We had people at our home for a going away party for my daughter, and it was 5 days later, and I got a phone call from a friend that her husband that was here at our home had tested positive for COVID. At that point, all of us felt fine. And then the next day, I got the headache and the coughing. I coughed. It was nonstop coughing. Terrible headache. But I really felt more like I had allergies, just kind of achy feeling. And that kind of went on for 4 days. I never had a fever. We took my daughter to Dallas. So we were there, and I was in a hotel room, and just because I knew I had been around somebody that was now positive, I stayed away from everybody there. And we got back to Kansas City on Sunday, and Monday my husband tested positive, and I called Dr. Nye's office, and I got a COVID test on that Tuesday, and mine came back that night that I was positive. The worst part at that point was just the fatigue and the achy feeling. I just didn't have any energy at all.
Mm-hmm. And then you actually thought at one point, I think, about saying we should stop your therapy for breast cancer because the COVID part, I mean, that is a dangerous combination.
So Carrie is on a medication that suppresses her immune system, and my protocol in my clinic has been when one of my patients has a known contact and has symptoms and we're sending them for COVID testing, I do ask them to hold that pill, which they take daily. She remained on another anti-hormone pill, which treats her breast cancer. But until the test came back, I had her hold that. And then once it came back positive, we held it until she was clinically improving.
And Carrie, tell us, what was the lowest point in your battle with COVID-19?
I probably, day 8 from symptoms, I started I started having trouble breathing. I just felt like I couldn't catch my breath and my fatigue was awful. That's when I ended up in the hospital at KU. So probably day 8 and 9, and I spiked a fever at that point. The CT scan showed that I had pneumonia, and I had a lot of pain in my lungs and my back area. The oxygen really helped me. Day 8 and 9 was probably the worst. It was difficult to get out of bed, to go to the bathroom, took a lot of energy. I expended a lot of energy I just didn't have. The worst part was being in the hospital alone and not knowing. And at home, I had 3 other family members that also had COVID, and a sister and her husband ended up being positive also from that. So the fear of the unknown and not knowing was it better, or the next day was I going to end up on a ventilator.
Yeah, that's hard. How long did it take you to get better?
I was in the hospital for 7 days, and then the fatigue and the cough lasted for about 6 to 8 weeks. I went home on supplemental oxygen. I used that during the day. If I was up moving around and doing stuff, I used the supplemental oxygen at night, every night for 2 to 3 weeks. It probably was eight weeks before I really felt like I had my energy back to what it was before.
You were really sick, Hawk. And so people like that, I mean, they can go one way or the other at some point.
Yeah, initially we thought, well, maybe if somebody's on immunosuppressive, they can stop that immune dysregulation, that inflammatory state. There's no evidence to suggest that. People who are on immunosuppression, whether it be people who are on hydroxychloroquine for rheumatoid arthritis, or people who have solid organ transplants or cancer chemotherapy, they seem to be just at risk too. So I think she did very lucky, and what she describes at that 9-day mark is really what we've talked about with the bimodal. It's the viral part of the infection first, and most people don't feel too bad with that, but then it's that later, that 10 to 14 days, she was a little bit earlier, where you start having the shortness of breath and cough, and that's when people tend to come into the hospital and need that supplemental oxygen. And so that's that bimodal part there, and that's exactly what she was describing.
And Carrie, what advice would you give to people now as you look back at what happened to you? What were the learning points that you would say to our audience?
Well, we felt like we were with trusted people and, a group of people that we had kind of been around since all this started. And everybody that was here, except for a few, had been working from home. It's funny because the people that are anti-maskers, I wear my mask everywhere in public. My family does. We have an immunosuppressed child also. And of all the people that didn't get it, it was him because, we're in the same home, but we were really good about masking and gloves when we went in to take care of him. He's completely dependent on us. And the fact that he didn't get it from all of us in the house that had it just showed me, really drove home the point that wearing your mask, social distancing, good hand hygiene, and cleaning the high touch items really proved to me that that's the best way to stop this and keep it, just based on him not getting it in our household with 4 of us positive.
Yeah, that's remarkable, and good job for that. And I think one of the challenges for folks is that you think, gosh, I can have this gathering. We think we're all pretty safe. But just as you thought at first those symptoms were allergy, that's what everybody thinks. Oh, I just got a little bit of a cold. I just got an allergy. Well, you see, exactly. That's unfortunately exactly how COVID presents. And so it's hard to know. And that's why the people just wear a mask. You can prevent this. Mm-hmm. We know the story of the hairdressers down in Springfield, where both of them, there are two hairdressers positive, 70 clients each, and everybody had a mask on. The client's hairdresser, and nobody got it. And my ministers allowed us to share her story. There was one member in a meeting that was positive, and there were 4 other people, and they were all, they tried to be socially, they all had their masks on. Nobody got it. And, masks work, and we know it on our own hospital ward, right?
Yeah, absolutely. on our own hospital ward, in the hospital itself, whenever you step on campus, masks are being worn. But especially in those units that we are seeing patients, or when our physicians are seeing patients in the outpatient clinic and the patients may not know they have it. But patients are masked, the physicians are masked. Up in the hospital, everybody is masked, eye protection as well, and we've seen the good results in the lack of spread when those measures are taken.
Yep. Keep Patrick safe. Wear a mask. Mahomes, that is. Okay.
Michael wants to know, if doctors right now were sitting in a normal air-conditioned room, would they be at risk even if you were 6 feet apart? And by the way, they love you.
Yeah, I don't know about love, but I'm kind of goofy.
Love, hate.
Hey, listen, the reason we can, A, we're 6 feet apart, B, this room has negative airflow. And negative airflow makes all the difference. So when we breathe out, our secretions are going straight up. This room's designed like that. We verified before we came in here and started taking our masks off what our negative air, how many air exchanges we were doing an hour. This is not your normal room, so don't try and mimic what we do. So it's a little different here. So we feel pretty safe because of that negative airflow, and the exchange is 100% with outside air. So we don't even recirculate the air into this room. So I think that really, we know we're in a pretty safe environment. If I was with this many people in a room without negative airflow, I would have my mask on. Pure and simple. I would have my mask on.
And we do in larger rooms when we're meeting.
We do, yeah. When we have our other conference rooms.
Even if you're spread 6 feet apart, we are doing that. I think there is still a risk there. The majority of the droplets are going to fall before 6 feet, but you never know. There could be a cough. Somebody could be drinking coffee and have a cough because of that, but they could be infected and spread it that way. So I think it is a higher risk potential for sure.
Yeah, it's real. Lauren, what do you guys do down in the cancer center to keep folks safe?
We've taken a lot of measures to keep our patients safe. We wanted to continue treatment throughout the entire pandemic and keep our clinical trials office open. And so everybody is required to wear a mask. We're only letting in one visitor into the clinic rooms, and we don't allow visitors in the treatment rooms just to allow for social distancing measures. All of our staff and patients wear a mask, and then we also wear the eye protection as well. And we've done a really good job at keeping our patients safe, and we want people to continue to come in for their treatment and for their screening. And then those that are uncomfortable, we offer telehealth, and so that is still an option, and I have many patients taking us up on that still, to see their provider via telehealth.
Yeah, I think I've had enough people decide they like that telehealth.
They do like that telehealth. They still have to come and get labs and treatment.
Yeah, they do. Well, when we tell them, you can come sometimes for telehealth, but we got to see you sometimes too, because there's something about, I'm still an old-fashioned doc, right? I've been a doc for many years. We're not going to say how many, that's a lot. But I still put a stethoscope on, listen to somebody, so you can't do that too well in telehealth yet. It'll come. We can't do it yet. How are you liking the telehealth?
I do. I really enjoy it, especially for our routine HIV patients. But there was a patient I saw yesterday for cellulitis, which is a skin infection. It looked good. I said the next visit will be telehealth unless you develop this infection again, because we need to do the physical exam, whether it's listening to their lungs and their heart, or looking at infected joints or infected skin or something of that nature. Telehealth helps a lot, but sometimes you definitely need that physical exam.
Manila wants to know, if everybody in the family gets tested prior to Thanksgiving, is it okay to get together?
Oh, man, I've been wanting to think the same thing for my family. What do you think, Hawk?
I think it reduces your risk. I think before getting tested, I really think you need to be self-quarantining 10, probably that 14 days where you're not going out in public. If you are going out to restaurants before that, make sure you are vigilant and at everything that you can do that we've just heard about with the masking, the distancing, and then maybe say 2 days prior to doing that, go get tested. That should leave you enough lag time to get that result back. That can help reduce your risk. Especially doing that pre-quarantine thing, the pre-Thanksgiving quarantine may help as well. I don't think that's a bad idea.
I think it's the only way to do it. Lauren, do you have kids? I don't even know. I'm asking these personal questions. Sorry about that.
I have two kids.
Personal.
Yeah.
2 kids, one in daycare and one in elementary school.
So it's going to make it hard for you to quarantine in a situation like that. So how are you going to do Thanksgiving this year?
We've been doing it since March.
All right. What are you going to do for Thanksgiving?
Well, my dad was going to come down from Chicago, but Chicago's not doing so hot, and Kansas City's not doing so hot, so I'm not sure if that's still happening anymore.
You can ride with your daughter.
That's where my daughter is coming down, but I don't know. I'm not sure carpooling's
I
a good
haven't sat in
idea
a car with someone since March.
Yeah.
Which
Carrie,
is a good segue to the next
well,
question.
let me ask Carrie what they're doing for Thanksgiving first. What are you going to do?
There's a few of us getting together, very limited family. I have a large family. I have 7 brothers and sisters. So not all of us are getting together for Thanksgiving for that very reason.
Yeah, I've heard said before, we usually have 25 to 30 people, and we have family, we have a few strays, folks who don't have somewhere to go. Come on over, we'll just have you here. And this year, I think there's going to be, I got to get my math right, 6 of us, right? 8 of us that are going to be there for Thanksgiving, and it's all people inside our bubble on a routine basis right now, plus my daughter, but she is quarantined in Chicago. And her boyfriend, they have quarantined successfully in Chicago. They're going to get a test the day they leave. They're going to come to Kansas City, and their tests get back pretty fast. And so I feel confident that she's going to be okay. But that is the struggle. Yeah. Even if you get tested right before, you could then turn positive the next day if you didn't have that self-quarantining for 10 days prior to the test. So you really have to do both things, otherwise you're not 100% safe.
Kathy wants to know, she says, the difficult thing about quarantining is staying away from grandma when grandma needs to go to the doctor and have a test done. She said, what is the best way in that situation to have somebody in the car, or should you?
That is a great question. My wife is faced with this very question today, and she's got to take my mother-in-law, her mom, to get her mammogram and things like that. And my mother-in-law, she gets mad at me because I give her age away all the time. But she's over 80. She's 88. And she is just as great a lady as you can imagine, and spry and bright and getting around. But my wife's going to take her. And so, my mother-in-law lives in independent living or Bishop Spencer Place, and so my wife's going to go pick her up and take her to get the mammogram. Is that an exposure to her? Well, yeah, it is. But if you both wear a mask, you're not in the car for that long, maybe you can crack the windows a little bit, get some airflow going, do things to mix up that virus if it's in there. But really wear a mask and then get in and get out. People are really safe inside healthcare. I mean, I really think it's not the hospitals or the clinics that expose you, because we are really doing a great job of working on that infection prevention and control stuff. So I'm really confident that patients are safe here. Really confident. In fact, we look hard to see if patients are getting infected while here, and we're not seeing it. So, and when we'd be real honest, because we would tell you that, just as we tell you about any other kind of things we have going on. So we don't see that. What we see is that patients obviously come in with COVID. I think that, but I think in that specific question, if somebody's wearing a mask, they're in the car, they got to get their health care, and then they go back home. I think that's the right answer.
Yeah, I agree. I think masking in the car, it's just like the hairdressers that we've talked about. So masking the car, the other patient or both people can wear eye protection as well. But I think that is going to be the important thing. And hopefully if you're living in the city here in the metro area, your drive to that other appointment is not too long either. But the masking of both participants in the car is of vital importance.
Yep, there is no absolute way to be safe. Well, bubble wrap, I suppose. But beyond that, there's no absolute way, but you got to go get your health care, because that's not safe either.
All right. Anonymous wants to know, if you've already had the coronavirus, is it safe to go and help care for someone that has or hasn't had it? And can you still shed the virus even if you don't have symptoms or are asymptomatic?
Okay, Hawk, let's do it.
Yeah, let's tackle that first one. So unfortunately, what we have seen from asymptomatic people, and some of these studies were done in Korea, where they had a very good protocol set up where if you were a contact of somebody, you were put into this treatment center for 14, 21 days, and they would monitor you. So in those studies, and in other studies too, they found that even, unfortunately, asymptomatic people with no symptoms, do create the same amount of virus concentration or titers, especially in their upper respiratory tract, and can spread the disease to other people. So even if you are asymptomatic, and that is why masking is so important, because if you have symptoms, you don't know you're ill, but you can still spread the virus to others. The first question about can you go and be a healthcare giver to somebody who needs it? You absolutely can, but that doesn't negate the need to continue to mask and social distance and do those things responsibly, because we know that you can get it again. But we don't know exactly when. Certainly most of the time we think 3 months or greater, so 90 days or greater. The first couple cases of documented reinfection were like 140 days, something of that nature. But we have seen documented cases at just over 60 days from their first infection as well. And we don't know what kind of symptoms are you going to get. Are you going to have no or mild symptoms, or are you going to have worse symptoms? So it's very important, even after you have had coronavirus or COVID-19, to continue to mask and distance and do those public health guidance measures to help protect spread of the disease, but also acquiring the disease again.
All right, so Jill says, I love Carrie Hallie Raleigh, and she wants to know from the doctors. She has heard that other hospitals have over half the patient census with COVID-19 patients. She wants to know if that's accurate and what is our percentage?
So, first of all, thank you for listening. Second of all, I don't know in Kansas City yet if there's actually a hospital that's over half COVID. Now, there are some that may be close, but they tend to be smaller hospitals around. But I don't know. Now, in other places there are. We know in El Paso, I think there was one hospital. I don't want to misquote this. I think they had 200 ICU patients and 600 COVID patients in one hospital, and I don't really know how big the hospital was, so can't tell you the exact percentage, but that's approximately a big number. And it was also true in New York at the height of the crisis and other places. In Kansas City, we routinely have about, let's say, 750 or 800 patients in our hospital. And so this morning, we said 100. There were 75 had active COVID, and 20.
Yeah, about 108 total.
108 total COVID recovering patients. So that comes to about 12 to 15% of our patient population right now has COVID, and normally it would be zero. There are other hospitals that have a higher percentage because they have a lot of COVID patients, but they have a smaller number of beds, and so their percentages may be in the 30% range. I think that's not uncommon. Over half in Kansas City right now, I'm not sure that that's accurate, and I would have to sit and talk with our chief medical officers and ask them if one of their smaller hospitals or something may have that. Now, I think it is true in some smaller towns. That is a very true statement with small hospitals. That could be true.
Brian wants to know if you could please clarify about the schools. He thinks that he has heard you say there's no transmission in schools. Is it no or low?
That's a great question. So Hawk and I will tackle this. We think when there's no is a very strong term. So when we say no, it's very low transmission within schools. But I think schools have done a great job of masking, dedensifying, and spacing. And we know those are the three main principles.
Yeah, I agree. It is low. I mean, no, like you said, we're meaning low. Certainly not the clusters or the outbreaks that we're seeing from other gatherings, say like funerals or parties or other gatherings that may be happening socially because of the measures that most all the schools have been able to put in based on their physical building size and the engineering. So it is de-densifying, not having as many students there, not having everybody come back on the same days, masking for everybody, continuing to maintain physical distance, things of that nature. From what I understand, it is very low compared to the other social type gatherings that we're seeing.
And I think that's the challenge. Carrie, just as what you experienced, right? You had a party inside your home. I'm going to guess it was inside, not outside. Is that right?
It was both, about half and half, about half inside and half outside.
But you have a group of people you think you're going to be safe with, and all of a sudden it's not. And I think with the schools can be relatively safe. The problem is the kids then gather outside of school or at a sporting event or out of track practice or football practice or, just hanging out, and all of a sudden there aren't any masks, and suddenly there's coronavirus being shared. And I think that's true without society. So do you guys go out very much? I mean, your family, you said you stay sheltered. Are you going out in?
No, we pick up, we bring in, my daughter is in school, she's a kindergartner, and my son's in daycare, and we have parents who are older, and so we want them to be able to see their grandparents, and so that's been our priority, is to keep our kids as safe as we can so that they can still enjoy time with their grandparents. So we pick really good dinners and bring them home, and we play outside with our neighbors, and we mask.
Yeah, so here's my cool weekend last weekend. I worked out. Right? And work out with a group of people. We're all outside. There's probably about 15 of us that day, but everybody's outside. Everybody's like 20 to 30 feet apart. So that's fine.
Yes.
Then I went to the only other things I did is I went by the K&K Fly Fishers to pick up something. Everybody's masked. I go in, I get out, get the stuff I need and leave. And then I went to the grocery store and I got gas. That was my big deal last weekend. And then I go to work every day, and that's kind of it, right? And other than that, I'm at home and I'm watching Star Trek, which everybody knows. How about you, Hawk?
It's a lot of walking, like around Lewis Park, the plaza. Trying to be outside. I can still do that even though it's not too cold, so we can still do that. But that's about it. Get some takeout for sure.
Takeout. We did Jack Stack last Sunday for the Chiefs game. That was good. It's usually Gates in my house. Well, we changed it up, and so you can have stuff. Carrie, what do you guys do for fun?
We've stayed home a lot. We haven't gone anywhere. My son also had a big spine surgery in June, so from about mid-March till June, we went nowhere. We stayed in. We weren't around people. Nobody came over, which is hard for us because we're pretty social people, but you can do it. We order out, we pick up meals to go, we do curbside delivery, and we've had grocery delivery. My husband is usually the grocery shopper, and I don't go out much anymore at all. I also have elderly parents, and we just want to try to keep everybody safe, especially seeing how, I've told this story before to many people, but when I was diagnosed and in the hospital, in our group, the week before, I was saying, I don't know anybody personally with COVID. I don't know anybody on my friends list, anybody personally that I know well. And then bam, 5 days later, there's 10 people in my immediate circle that are positive. So it's scary and it's frightening how fast it happens and who gets it and who doesn't, especially in a large group we had of a baby all the way up to, somebody 75 and the 10 of us that ended up with it. So we don't do much anymore, and we just moved. So we're definitely, we moved with the help of nobody, and we just stay home. I go to my appointments and they're super safe at the cancer center. And we just don't do much.
Yeah, that's the way it is, huh?
Yeah, and unfortunately, like we said, we can still do things outside, exercise. It's not too cold. Sitting outside, especially if it's rainy like today, it's going to be a little bit more difficult. But as we get into this colder weather, people are going to want to move inside. They're going to want to watch Jayhawk basketball. They're going to want to watch the Chiefs together and gather. And just as you said, you think these people are close to you, you understand, but you don't understand where they have been to. And so all these bubbles interconnect. And there is a very good website that shows what is the risk if I'm going to go to a party, and what is the risk of one person there having COVID-19. This is from a separate website. I can't remember exactly where it's from. But anybody can go to this and type in COVID-19 event risk assessment planning tool, and you go to specific counties. You can also put in how many people are going to be there, 10, 15, 25, 50. Currently in Johnson County, if you have 15 people at a get-together, there is almost a 40% chance that one of those people will have COVID. And
that tool helps you figure that out.
That does.
I bet you can Google the COVID-19 event risk assessment planning tool, and you'll probably pull it right up.
It's terrifying.
It is. So you've been doing it too? Mm-hmm. Okay, well, I'll make sure I'll check that out. So, all right. Well, final thoughts from the day, Dr. Nye?
Thank you, Carrie, for being here today and sharing your story and reinforcing that the Cancer Center is a safe place to be, and we're here to take care of our patients, and we're continuing treatment, and we are, with the help of our colleagues, battling COVID at the same time, but our goal is to continue our cancer care.
And Dr. Nye, thank you very much for being a part of the program today. It's been great. Carrie, sharing your story and telling it in such a heartfelt way has been the best thing, and we thank you so much for being a part of the program today. That was awesome. Hawk, any final thoughts from your standpoint?
I think there have been a lot of announcements yesterday and today, and there continues to be a lot of hope as we move forward and optimism, and we will keep everybody updated on any new changes and any new press releases that are released by the vaccine companies, by the therapeutics companies, because right now there does, although it is a very dark time and we could be moving into a darker winter, there is also a lot of cause for hope and optimism. But we need to remember to do the important things, and that's the behavioral things. That is the masking, the physical distancing, not meeting in gatherings, doing the hand hygiene, because that is going to be what is most important now and what has been most important historically throughout this pandemic.
So tomorrow we pay tribute to veterans. Justin Hoover, the executive director of The Battle Within, updates changes in the stigma around mental health due to COVID-19. Craig Crumpton also will join us. Craig is a veteran, alumni of the Battle Within, and a firefighter and Air National Guardsman. He also recently tested positive for COVID-19. So, big day tomorrow. We also have an important thing from We have an announcement here, a message from Archbishop Joseph Naumann on mask wearing. As we close in, the Archbishop will share his thoughts. He's Archbishop of Kansas City in Kansas, and be talking about mask wearing and science. As we go to that, I want to leave you with that thought. And the thought is that sometimes in the darkest moments is when you can find the most important hope. I think we are headed to the hardest months of this pandemic. I don't think there's any question about it. The numbers are on the rise in Kansas City. People are going inside. You're coming up on the Thanksgiving and Christmas holidays, and they're going to be much different this year. And so that's going to be hard. A lot of people have economic stress. You know, one of my favorite men's store I go to and shop at, or one of them is closing. I mean, things, you know, it's hard to watch things that you're tied to close and parts of your life change like that. And that's really hard. But I think Carrie said it perfectly today, because her life got turned upside down. And COVID will do that to you. And COVID's real, and it's out there. And we know how to beat it. It's not a superhero. You can bend the curve if you follow the rules of infection control. And it's never been more important than it is right now, especially because we are just months, weeks away from having a vaccine that's already approved and getting it and giving it to people. We are weeks away from giving you antibody therapy we didn't have before, that we will be giving to you. It's been approved. So these are game-changing moments. Stay alive and stay in the game. Wear a mask, follow the rules. Let's listen to what the Archbishop has to say.
I can tell which cable station people have been watching by the letters I get. They think we're too restrictive or we're too permissive, depending on where they're getting their news information. The scientific method came out of a Christian culture, and it's only if you believe that there is design in the world, in the natural order, that science really makes sense, and that leads you to a belief in God. He protects us, but part of the way he protects us is by prudence. We can't just simply ask God to perform miracles when we can protect ourselves by being prudent.
Come on, Grandpa.
This guy's grandpa is going to attempt to drive over this massive crack in a 70-year-old classic Jeep. It has no power steering, no huge tires, it's not been lifted, there's no modern tech. We're looking at a Jeep that came out just after World War II. Let's watch how he takes on this massive crack. Question is, will he make it?
You're going to be fine. Straight, wheel straight. You're going to come on and touch that thing. Just go ahead and touch it. Come on. Just come on. Let it come. Okay, you're touching. You're on it. Okay, come on up.
Oh!
Okay, easy now. You need to... No. Okay, I think you need to come my way. You need to come... Well...
Hey, I don't want to
Well, I was guessing.
It's a 1948 Willys CJ2A.
I think you need to be straighten your wheels out.
Oh, look how tough it is to turn that wheel. That's insane.
Straight. Well, okay. You got, yeah.
It's actually known as the golden crack.
Okay, I can't. gonna do that, you gotta come on. But you're like, your tire's like about 4 inches from that wall. But if you, but if you can't come up, you're gonna start tilting. So
Can he do it, or is he stuck?
you're on your bumper. You can't. Try it. Come on. Keep coming. There you go. Oh. Okay, that's it.
Yes.
Okay, you know what to do now.
Front tire's out. Will the back tires make it through?
Come on.
Yes, and the power pump at the end. That was awesome. So this Jeep was actually made to replace workhorses back in the 40s. It was marketed to be able to do the work of 2 heavy draft horses out on the fields.
You gotta come straight, like right at me. Straight.
Original cost of this car, just over $1,000. Oh, imagine what that'd do to your rims. Look at the condition of this car. I don't think he minds a couple of scratches here or there. He's loving it. Nice job.